also like to thank everyone for attending today's webinar. It is a very interesting topic for me. It's something that I've given past talks on and published a couple of articles on this as well. So it's an area that I'm very interested in. I'd also like to thank Sakura for the opportunity to present this webinar. The objectives of the webinar are to first overview the pathology grossroom duties, both in the histotechnician, the PA, and the pathologist role. Define the role of the histotechnician, histotechnologist in the grossroom, and then also to review some of the regulations that apply to performing duties in the grossroom. The anatomic pathology grossroom is where we receive the specimens and accession them. We receive various different forms of specimens. Some of them are fresh. Oftentimes they are formalin fixed. They come from inside the hospital, but also the hospital-associated clinics and even off-site. The primary role of the histotech in the grossroom is to log in specimens, prepare cassettes, and to make sure that everything is ready for the PA or the pathologist to gross in the specimens. Grossing in includes the primary analysis, which is simply the observation and dictation of what is seen with the gross specimen. It can involve dissection, depending on the size of the specimen, which is variable per tissue. Marking, which includes edge analysis, which may be pre-marked by the surgeon, but also further marking required for larger specimens as they are dissected. Sampling, which is placing the tissues into the tissue cassettes and storing the remainder of the tissue, and finally issuing the report. The HT/HTL grossroom duties include preparing the specimens for review, accessioning and labeling, cryosectioning during the surgical procedure, stocking the grossroom, making sure that all the supplies are present, cleaning and disinfecting after the pathologist has completed their duties. And finally, and an area that I'm going to discuss today, is grossing in the grossroom for the histotechnician. Now, in most training programs, histotechnicians are not specifically trained for grossing. In fact, before 2001, it was included on the ASCP Board of Registry exam. There is no longer a grossing component on that exam, although the NSH still releases their self-assessment examination booklets, which one of those booklets describes gross dissection and description. So it is still out there in the literature, although again it's not something that's widely taught in the histotechnology or HT schools. Of the textbooks available, the most popular textbook for these schools, the Carson textbook, does not mention grossing as a role for the histotechnician. Bancroft's Theory and Practice of Histological Techniques does have a chapter on grossing, but it's very, very brief. On the job training programs, depending on the specific site that's doing the on-the-job training, they may include grossing as a component of the histotech's duties. Now, traditionally, grossing has been separated from what we consider to be grossing in smaller specimens, which at the time was called processing. So processing and grossing prior to 2010 were considered two separate duties. It was acceptable for histotechs and histotechnologists to do processing, which was essentially grossing smaller specimens, and then the larger specimens was considered grossing. Now, these two definitions are still somewhat in play in that if you're considering having the histotechnician or histotechnologist do the processing of specimens, you can separate them into the two levels of tissue examination. So again, the earlier nomenclature was that processing involved limiting to a description, some minor inking, and perhaps a cutting of the specimen, and then submission of the entire specimen in toto to the histology laboratory. Whereas grossing was defined as requiring judgment and knowledge of anatomy and specifically anatomic pathology in the dissection and selection of tissue samples. So the specimen description was not standardized. It was different for each specimen that came into the laboratory, and it required what we called high complexity testing, whereas at the time processing did not. Now, for non-pathologist tissue exams, in order for anybody who's not a pathologist to do these exams, the extent of the activities that they're performing must be well defined. They must have a clear protocol in place for the non-pathologist to do the tissue exams. The nature of the pathologist supervision also has to be defined. How often are they reviewing the protocols? How often are they reviewing the actual grossing of the non-pathologist? And this also has to be spelled out in protocol as to how often they're going to do these overviews. So again, periodically, indicates that it has to be at defined intervals that are spelled out in the protocol. This lab policy is something that during a CAP inspection they will take a look at in the anatomic pathology checklist 11640. Specifically defines the periodic intervals must review the grossing. Now there's a series of anatomic pathology protocols that are on the CAP checklist that deal with grossing. Generally these protocols are all between 11600 and 11650. These protocols include ANP 11600, which talks about the gross examination. And specifically I'd like to point out that it states that all macroscopic tissue gross examinations are performed by a pathologist or a pathology resident or under the supervision of a qualified pathologist. That includes specific requirements for supervision of non-pathologists who assist in grossing specimens. Now 11605, which was recently revised, deals with more pertinently people who are not pathologists grossing in. So it specifically states that when individuals other than a pathologist or pathology resident assist in gross examinations, the extent of their activities and the nature of the supervision is defined in a documented protocol. So again, it comes back to making sure that these protocols are in place and a different protocol for every type of specimen that could be encountered in the gross room. Now the third one, again, which pertains directly to histotechnicians, 11610, states that if individuals other than a pathologist or pathology resident assist in gross examinations, such individuals qualify as high complexity testing personnel under the CLIA regulations. Again, if we look back at the differentiation between processing and grossing, the College of American Pathologists did not initially think of processing as high complexity testing. So in the CAP accreditation checklist, there are three main questions that come into play when having somebody else other than a pathologist gross. The first one is, are the macroscopic examinations conducted under the supervision of a qualified pathologist? Are non-pathologist duties defined in a documented protocol? And finally, is the performance of a non-pathologist evaluated by the pathologist on a regular, periodic basis? The regulatory requirements have been cleared up recently. They first were expressed in the CLIA regulations of 1988. CLIA regulations are the regulations that are listed from the Centers for Medicaid and Medicare Services under the Department of Health and Homeland Security. The CLIA regulations are CFRs that specifically state who can do what types of work in the histology or in the laboratory in general. Specifically, subpart M of CFR 493, etc., just states that defines grossing as high complexity testing. Now, high complexity testing was considered to be part of grossing, but again, there was the differentiation between grossing and processing at the time. In 2010, CLIA sent a letter to the College of American Pathologists that clearly stated that there was no differentiation between grossing and processing. So now, as of 2011, CAP considers both high complexity testing and therefore says that the lab must have a protocol for non-pathologist grossing the specimens, and these individuals must be approved for high complexity testing. So coming back to the role of the histotechnician in grossing and processing, in order to be approved for high complexity testing, the histotechnician must have current state licensure in states that require state licensure, which include New York and Florida. They also must meet one of the following requirements. They either have to have an associate's degree in laboratory sciences from an accredited institution, or at least 60 hours of classes in lab science, and with a combination of biology and chemistry and 3 months specific training in that area. Now, previous to these requirements, the CLIA requirements, there were people who were grossing and continue to gross in the histology laboratory who received no formal training at an accredited institution and do not meet the 60 hours requirements. Prior to 2011, these people were all grandfathered in. In other words, since they were grossing all along, they were considered to be acceptable to continue grossing from that perspective. After 2011, CLIA requirements specifically stated that they now have to meet high complexity testing measures. Now, this doesn't necessarily mean that those grandfathered in must stop grossing. What it does state, though, is that anybody who's continuing to gross and who does not meet those high complexity testing requirements can continue to gross in specimens as long as the protocols do not change. Any changes to the protocol require that person to now meet high complexity testing regulations. Now, the training for grossing deals with more than certainly in a 1-hour seminar or other seminars that you might see. Typically, this is a fairly advanced course in surgical pathology. Typically, a 16-week course that goes over both the specimens and the pathological process is the starting point for having people who are non-pathologists actually doing the grossing. So PAs already take a course in surgical pathology. It is recommended that HT schools increase their exposure to surgical pathology. Now, one of the problems with increased training at HT schools is that HT schools have already increased training in areas such as in situ hybridization, immunohistochemistry, and other high complexity testing. So to include grossing in that may be beyond the scope of what the HT school's target is. And again, since it's not covered specifically on the Board of Registry, it's not something that most HT schools are going to be interested in covering. So a lot of hospitals, and I'll mention Children's Health Dallas because they also have given a course in training and they've given a couple of different seminars on Histotechs grossing. They've developed their own in-house training program. This includes a approximately 16-week course, which includes study materials, testing, homework assignments. They also want them to shadow either a PA or a pathologist and document all of their training before they're released to be grossing in the gross room. After they are documented to have passed all of this training, they have to enroll in continuing education, which can be something such as the National Society of Histotechnology offers workshops. In fact, the annual meeting, which will be going on this September, has a grossing workshop given by Min E. So for pathologists to gross, they're going to see all of the different specimens, but for histotechnicians and histotechnologists, it's recommended that we divide the grossing into different levels. And this can be accomplished just by looking at the specimens that are typically processed at the site and determining if they are level 1 specimens, which are simple biopsies, which require simple processing and a very brief grossing. Level 2 can include routine surgical specimens, whereas level 3, which is typically handled by the PA or the pathologist, would be the full-time grossing, the larger specimens, and specimens that require a great deal of resection or description of the pathologic process. So for the remainder of the seminar, I'd like to discuss some grossing principles. And again, this is not intended to be a training program for grossing, but rather introducing you to what grossing entails and to give you some guidelines as to if you're thinking about having Histotechs gross in the future at your facility, some things to think about when they're being trained for that procedure. So some basic rules to adhere to in the gross room, gross bench rules. Probably the most important one is never to have more than 1 specimen out at any time. This limits the possibility of carryover or the possibility that a specimen from one patient will be mixed in with a specimen from another. All containers should be closed if the grossing technician leaves the grossing area. It should be kept clean, neat, and well organized. And this isn't just for carryover, but it also has to do with the potential for safety hazards. There are many sharps that are on the gross counter. Typically, these are attached to magnetic holders, which can keep them in clear view, but it is important to keep track of all the sharps that are being used at any time just to limit that mechanical safety hazard. One other note on carryover, specimen identification errors do occur in anatomic pathology, and they occur, luckily, fairly infrequently. Approximately, in a recent study, they noticed that 4.3 out of 1,000 surgical specimens were either mislabeled or in some other way the patient ID error occurred. During the amendment procedure, they still found that 1.9 out of 1,000 reports were also had patient ID errors. Another report found that 19.2% of amended reports were due to patient ID errors. So patient ID errors are, while they're not common, they are certainly an area of concern. In order to reduce errors, most hospital laboratories have switched to specimen identification numbering systems, specifically designed to separate things like surgical cases from autopsies, GI specimens, etc. Another thing that they've incorporated is barcodes, which barcodes serve 2 main purposes. They aid in the cutting of the specimen. When the grossing technician is grossing in the specimen, they can compare the barcode on the label to the barcode that's on the cassette itself. And it also helps with protected health information, the HIPAA laws. We don't have as much information on the cassette itself, The barcode can relate directly back to the laboratory information system, which contains all the patient information. And when grossing specimens, there are a couple of additional considerations, and those are specimens that are gross only and specimens that are excluded from grossing. Now, both of these classifications of grossing specimens can be grossed in, and some hospital laboratories will gross them in and have the histotechnologist process them, cut them, stain them, and have them read microscopically by a pathologist. But according to CAP guidelines, there are some things which are only grossed. These include non-tissue components, such as bullets, implants, or other foreign bodies, and then some tissues that are removed generally for non-pathological reasons. Tissues that can be excluded from grossing also include many different tissues that are either implants or tissues that are removed in routine processes that do not involve pathology. One particular thing to note on here is placentas from uncomplicated pregnancies is on the exclude from grossing lists, whereas most hospitals that I've worked at or visited have included placentas in their grossing, sectioning, staining, and review by pathologists. So again, these are CAP guidelines. They don't necessarily mean that this is what's always done at each one of the hospitals. So to look at the dissection that we're going to discuss, or the possible grossing applications for the histotechnician, we have to come up with an idea of where to start. There's an endlessly diverse group of samples that could come into the gross room. Oftentimes with resections, we have very large tissues with confounding complexity, and it can be very overwhelming. So where do we begin? Well, first off, we have to decide what's going to happen in the gross room. What is the role of the grossing technician? And essentially, the grossing technician is trying to answer three fundamental questions for every tissue that is presented. Number one, what are the structures that are present? They should be analyzed and described. Number two, what is the nature of the pathologic process? And finally, how extensive is that process? Now, even though we have these three fundamentals of questions for dissection, there are some variations that are available as well. This one was adapted from the IU Health Systems Gross Surgical Pathology Dissection Manual, and it involves 7 different questions that the grossing technician should ask themselves, such as, are all the parts present according to the requisition? Do I have an adequate patient history? What is the main specimen? What information will be essential to properly sign out this case by the pathologist? What are the minimum number of tissue cassettes? Are there any additional pathologies which were not noted by the surgeon? And then based on the information that I delivered during the gross examination, have I justified the nature and extent of the surgical procedure? So these, again, questions aren't set in stone. There are variations, but certainly there are some fundamental questions that we have to ask. In order to address those questions, I recommend 4 fundamental steps in addressing them. The first one is specimen orientation, essentially making sure that the specimen itself is in anatomic position as if we were looking down at the table at the patient. Specimen orientation is critical with larger specimens because we oftentimes need to mark the margins, medial versus lateral, superior versus inferior, deep specimens. All of those terms come into play with specimen orientation. If the pathologic process goes beyond the borders, we want to know exactly which borders they go beyond so that the surgeon can go back in and remove more of the tissue as needed. The gross description, that's going to be, again, just a description of what is seen. It should be succinct, logical, and factual. Dissecting the specimen. This is different than sampling the specimen. In dissecting the specimen, we're essentially cutting larger specimens into smaller pieces so we can look at the pathologic process in every component of the tissue itself, not just on the visible components. And finally, the 4th step is specimen sampling. This is important for larger specimens in that they cannot be submitted in toto, and so we're going to sample the critical components of the tissue. To start with training for histotechnicians or histotechnologists, there are a group of what we considered previously to be process tissues, tissues that are small, tissues that require embedding in toto, and tissues that have a very brief description. So things like GI biopsies, cervical curettage, bladder biopsies, they're all fairly small in size. They do not require orientation. Again, they are submitted in toto, so there's no sampling involved. And these are generally very small specimens that traditionally have been fallen under the processing category. Now, in processing these biopsies, we need to note the number of pieces per container, the size of each piece, or if there's a conglomerate of pieces, the range of sizes, sometimes even the weight. Now, this pertains more often to larger specimens. A macroscopic description of what we see. Now, this can include photographic reports as well. Back previously, especially 15, 20 years ago, this photographic representation of tissues wasn't always possible because of film, but now with digital cameras, it makes it much, much easier. And then finally, inking the specimens, things like prostate, where we have to ink the margins, the edges, etc. That's part of the processing. So first off, looking at the small biopsies, we want to refer to the size of the specimens. With only one sample, it becomes fairly self-explanatory, length by width by height. If there's two or more of the same size, we mention both of them and then one description. Two of different sizes, or if we have three or more, we'll oftentimes say we have a range of specimen sizes. For an example, we might have endocervical curettage, and a dictation of the specimen might be, parentheses, specimen consists of multiple fragments of pink, tan, irregular soft tissue admixed with mucus and blood, having aggregate dimensions of length by width by height in centimeters or millimeters, which are submitted in toto in a single cassette, comma, levels are requested, period, end quotes. So this would be the template for most often endocervical curettage, and can be followed, and it can be posted at the grossing table with areas delineated for filling in the blank, essentially. Now, with these smaller specimens, it's oftentimes not very clear if we need to cut into them or not cut into them. Most diagnostic cases do not require additional cutting or inking. Again, they're fairly small specimens. Some general guidelines include size. For instance, if GI polyps are greater than 5 millimeters, they should have their bases inked and be bisected. Same thing with endometrial polyps. Punch biopsies, if they're greater than 4 millimeters, oftentimes are bisected, especially if we're talking about skin punch biopsies. So listed here are just some examples of the dictation that you might see for these smaller samples. Again, what I want you to note here is that they're all fairly succinct. The preliminary diagnosis is given in the requisition by the surgeon, and so it's put in parentheses, and then it's just an overall description of what is seen. Now, for complex cases, I'd like to point out that, again, this is not a intensive course in processing these complex cases, just some general guidelines on how they would be grossed in and some things to look for. So again, we come back to the four basic components of grossing, and the first one, as I mentioned, was specimen orientation. This is critical for these larger pieces of tissue. Oftentimes it's a confusing conglomerate of tissue. If we place it in anatomic position, it'll be more logical how we're dissecting the specimen and what margins we're inking. So one of the first things we do is look for landmarks. Shown here is a radical mastectomy. The landmarks here are fairly clear. The skin is obvious, but also the surgeon has placed sutures marking the different areas. So they might have inferior versus superior. Notice a single stitch in the superior margin. And then medial versus lateral margins will have either 2 stitches or 3 stitches depending on the requisition and the surgeon themselves. The important thing is that by reading the requisition, we can place this tissue in anatomic position. The requisition form, in addition to containing the anatomic position, might also contain some additional information we should be aware of. Any differential diagnosis, the operative findings, the type of procedure that occurred, but also things like safety. If there's a biohazard issue, special requests, they might request levels, or they might request special stains or histochemical stains. So all of that should be included in the requisition. So it becomes valuable to have the requisition and the gross specimen at the same time. With specimen orientation, it's important for communication with the surgeon. I already mentioned location of sutures, but also looking for, did they obtain sentinel lymph nodes? Did they already ink the margins in the surgical suite? And now, in addition to the sutures, we have the margins which are pre-inked, so we know which margins we're looking at. The second part is the gross description. again, we're thinking in advance as to what the pathologist is going to be looking for. So the pathologist is looking at a microscopic slide in 2 dimensions, and they're thinking in their mind based on the gross description what it looked like macroscopically. Again, occasionally there are even photographs to aid in this visualization. In order to aid the pathologist, we must make sure that our gross description is logical, factual, and succinct. Characteristics include what is the source tissue, the size of the components, if there are different fragments, the type of biopsy that was obtained, the weight of the specimen, color, shape, and consistency as well. And these are things that the pathologist cannot see in the 2-dimensional slide. Any abnormalities should be noted. Oftentimes, especially with things like radical mastectomy, palpating the specimen, the person grossing can find sentinel lymph nodes, things that might not be readily apparent just by looking at the specimen. The margins should be inked, and again, here you see some images of inked margins as they appear to the pathologist when they're looking at the microscopic slide. And the importance, of course, of inking the margins is to make sure that the pathologic process is completely contained. Any photography, again, for complicated specimens, photography is oftentimes included. Now, one of the things to keep in mind is that somebody grossing in these larger specimens has to keep in mind the pathologic process. And oftentimes the pathologic process in the anatopathology laboratory involves cancer or the neoplastic process. Part of grossing is thinking about these stages, stage 0 to stage 4, in terms of how it's going to affect the patient treatment, the diagnosis, and the prognosis. So stage 0 is defined as in situ carcinoma with clear margins. We've completely removed it, versus stage 4, which not only has the cancer metastasized to the lymph nodes, it's also metastasized to different sites in the body. So in thinking about the neoplastic process, it's going to help by thinking of the subcomponents of the staging. They include the T, N, M scores. Adding up the T, N, and M scores will give us the different stages. So T is tumor size and spread, N is any lymph node involvement, and any metastases to distant sites will always be characterized as a stage 4 type of cancer. Staging is different for every tissue. The American Joint Committee on Cancer publishes cancer staging handbooks and atlases to help the grossing technician and the pathologist reading the eventual slide, looking at their overall stage based on the grade or the microscopic features of the tumor itself. So the third step is then dissecting the specimen. So after the gross description, and the gross description doesn't have to necessarily come before dissecting, it can be in conjunction, and certainly back and forth after the specimen is dissected, especially if something is found when opening up the specimen. So again, just some basic safety guidelines for the cutting station, making sure that's clean, orderly, contained, proper ventilation and light so we can see the specimen clearly, and even something simple as maintaining the moisture of the specimen. Something such as a spray bottle can be sprayed with saline on the specimen to make sure it maintains moist during this dissecting process. Some of the tools available include, of course, sharp knives and scissors, but also there are some specialty tools that are designed specifically for the gross room. The grossing board should have a depth adjustment, and that can also be problematic because occasionally tissues can be trapped underneath the gross board, and then we have the potential for tissue carryover. The varying sizes gauges are shown in the upper image on your screen. The different gauges aid the pathologist in cutting the specimen to a certain width. So rather than freehand cutting, the gauges allow us to cut 2 to 3 millimeters width of these sections, and the tampers help hold the specimen in place so there's not a risk of potential cutting into the pathologist or into the grossing technician while they're cutting the specimen. Another handy tool is the grossing fork, which is shown in the lower picture. The grossing fork is essentially a hollow fork of a set width, it could be 2 to 3 millimeters, and is placed into the specimen, and then tissue is cut around the grossing fork. So inside that open cavity of the grossing fork is the specimen itself cut directly to that size, and there'll be different size grossing forks depending on the thickness of the specimen required. Some additional things to keep in mind when dissecting the specimen is the next step, step 4, which will be the sampling. So with dissecting the specimen, we want to dissect it with the intention that we're going to then sample components of it. Now, in handling the specimen, we don't want to ever have any more than one specimen at a time on the gross bench. And also important, we don't want to keep like samples together. So there might be a table that has all the specimens that are going to be grossed in for that day. Like specimens should be separated so that there's less chance of carryover between specimens. With opening and sectioning, we're taking a look at the inside of the tissue. But when we go to sample that, we want to keep in mind the rule of thumb. The tissue should be no larger than the size of a nickel. Anything larger than this, and hopefully this is in the past, but as I recall, the pathology residents, oftentimes they were trying to cram in as much tissue into a single cassette as they possibly could. This, of course, limits the ability of the fixative to penetrate into the tissue, and we end up with autolysis on the inside of the tissue, whereas the outside of the tissue is adequately fixed. So the nickel is a good rule of thumb for the overall size of the tissue. And then in dissecting the specimen, in order to keep track of what specimen came from what section, that also will involve inking of the margins to keep that anatomic location in place while we're dissecting the specimen. Following the dissecting and before the sampling, we think about pre-processing, how these specimens are going to be processed. Most oftentimes they'll be fixed in neutral buffered formalin. Some general guidelines include the idea that formalin only penetrates 1 millimeter per hour. So we want to make sure that that size of the tissue is adequate, that the neutral buffered formalin will penetrate. Formalin should be approximately 10 times the volume of the tissue itself. A lot of textbooks say 10 to 15 times or 15 to 20 times the volume. You can't really have too much formalin, but you can certainly have too little. Decalcification can occur not just in bony specimens, but also in specimens that have calcification present. Holding solutions are special solutions that can be used that they're not fixatives, but they'll keep the osmolality of the tissue balanced. This is important if you don't want to fix the tissue quite yet. You still have some additional processing to do, but you don't want the specimen to dry out. Molecular fixatives and hardening solutions are oftentimes alcohols that will be more useful for specific applications, such as in situ hybridization or immunohistochemistry. And then finally, if we're going to store the specimen, we're going to keep it for a longer period of time, it should be switched to an osmotically balanced storage buffer, typically anything in the range of 300 milliosmoles per kilogram. With our tissues in the gross room, we want to maintain those tissues at least until the final report is issued by the pathologist. So general retention periods, according to the CAP guidelines, say that we should keep our accession log and our QC record for a minimum of 2 years. Our wet tissue is only kept for 2 weeks after the final report is listed. And this is an important note because the wet tissue might be, there might be a while while we're waiting for the final report, especially if we have advanced testing such as in situ hybridization that has to be sent out to a distant site. So the wet tissue, again, 2 weeks after the final report. A lot of places keep their tissues much longer. These are guidelines, these are the minimums that CAP recommends. You can see that for autopsy specimens, paraffin blocks and glass slides are kept a minimum of 10 years. Many sites keep them much, much longer than that. So we've cut into the specimen, now we're going to sample the specimen. There's some general guidelines that apply to sampling. For small biopsies, this really isn't an issue because most small biopsies are sampled in toto. So the entire tissue is placed into the cassette for processing and subsequent staining. Very small specimens we need to take care to make sure we don't lose any in the cassette, which can oftentimes require specialized cassettes or the regular cassette as long as we have the tissues in sponges or in some form of mesh bag. In dermatologic specimens, for punch biopsies, most punch biopsies less than 2 millimeters are embedded in toto. Now this is again is the embedding process, so whereas the grossing might be the entire specimen is sent in and not dissected, when the histotechnician goes into the embedding center and embeds these specimens, that's when they might actually bisect the specimens. And so typically anything larger than 2 millimeters is bisected, and if it's very large, it might also be cut eccentrically, as shown in the third picture, just to make sure that if we are doing aggressive cutting in the initial cutting stages, we don't cut completely through the pathologic process, which would be shown in red. Other concerns for dermatologic specimens not pertaining to Mohs, which is a completely different procedure. Mohs sampling is detailed in other in other talks. This is talking about dermatologic specimens, that different ways of obtaining those specimens, which again can include punch biopsies, but can also include shave biopsies. And shave biopsies in particular oftentimes are thoroughly cut. They can be bisected, or they can be trisected, or even cut into more sections. And it's important that each of these should be embedded on edge, which is typically included in the requisition. For larger biopsies, we want to take a look at landmarks, again, place them in an anatomic position, ink the margins, and then submit them in smaller sections for processing and staining. Other accessional specimens other than skin, we want to make sure we examine the depth of the invasion. So this is going to be more of a process whereby the pathologist assistant is examining the tissues and determining how many cassettes are going to be required to understand that disease process. I mentioned again that understanding the underlying pathology is very important, which is why these larger specimens should be handled by a PA or a pathologist, because the disease process in general will affect how the processing and grossing is done. For instance, with breast cancer, we know that most often the breast cancer will migrate to the lymph nodes first, but then distant metastases might be to the bone or brain, whereas colorectal cancer will metastasize to the lymph nodes, then the liver, versus ovarian cancer, which tends to spread out through the peritoneum. So in processing these specimens and understanding the disease process, it will help us with what tissues we're looking at and why we have different tissues, perhaps even in the same container that's sent from the surgeon. So some general approaches to sampling, again, they're going to be different per specimen. Some things to keep in mind with the neoplastic process, we're probably going to do immunohistochemistry. It's going to be different on each one of our specimens, especially with pediatric specimens, where there might also be electron microscopy, flow cytometry, and molecular specimens, which may require touch preps in the gross room. When sampling a tumor, it's important to align the tumor and cut through it so that we can see the pathologic process and make sure we completely contain the entire tumor itself. The sides or the periphery are much more important than the center. Typically the center is homogeneous. It doesn't really tell the pathologist much. The heterogeneous side of the tissue gives us the margins and makes sure that the pathologic process is not extended beyond those margins. So in sampling a margin, it's more important to do a perpendicular cut into the specimen to get the pathologic tissue as well as the non-pathologic tissue. The parallel cut can give us some more information about the margins, but again, it doesn't give us a lot of information about the invasive process of the pathology. With lymph nodes, oftentimes sentinel lymph nodes are cut into multiple different pieces. And again, this will vary per protocol. The sentinel lymph nodes, we want to make sure that if the disease process did migrate to the lymph node, we have all of the lymph node cut through. So it'll usually have multiple cuts and multiple tissue cassettes for the number of different lymph nodes we have. Lymph nodes in something such as a radical mastectomy can oftentimes be numerous different cassettes. So a slide index is important to keep track of all the different tissues that were submitted from a single specimen and all the different cassettes and the number of tissue pieces that are in each cassette. This will also be important for the histotechnician when embedding the tissues to make sure that all the tissues that were supposed to be present in the cassette are actually present. In selective tissue sampling, we want to make sure that we get representative pieces of what we consider to be important. And for larger specimens such as the placenta, we want to make sure that we have representative and obviously cannot process the entire tissue in toto. Some additional concerns beyond just the practical considerations for grossing include things such as billing when grossing. So these are some things that the grossing histotechnician must keep in mind as well. They must be somewhat familiar with the current procedural terminology of the CPT codes, as well as ICD-9 codes, which we've now modified to the ICD-10 codes. So the Healthcare Common Procedure Coding System is the codes that we use, the current procedural terminology codes, which describe the actual service that's being rendered. It's divided in general into level 1 and level 2. Level 1 is the primary code system that we're interested in, and that will be important not just for making sure that the billing is handled correctly, but also that we're being consistent across the board in various different hospitals processing the same tissues. The ICD-9 codes are associated with the specific disease itself. And again, we've migrated to the ICD-10 codes now. The ICD codes are important in that it describes the pathologic process and should also link to the CPT codes, because the CPT is more for billing and the ICD-9 or ICD-10 has to be consistent with what we're billing for. So to summarize some benefits for the HT-HTL grossing, the HT understands the entire process from when it's removed in surgery to the processing, the embedding, the staining, the cutting, etc. It can result in cost savings for the hospital. It can meet demands of a workforce shortage. There are currently only 7 PA training programs in the United States, so they're in high demand. It also allows the histotechnician to rotate through other areas instead of just cutting or staining or embedding. Recommendations would be include to, if you're considering setting up a program, to start early. Typically it's about 6 months to draft these guidelines, an additional 6 months to train the technician in order to do the grossing. Work with pathologists and administration should be all along the entire process to make sure, number one, we get buy-in from the administration, but also to make sure that all of the guidelines and reports are signed off. I mentioned Children's Health System earlier. This is an example of their project plan for grossing anatomic pathology technical personnel. Again, this is how they started the program of how are we going to begin Histotechs grossing, all the way up to the point of we now have them trained and ready to gross. They have policies on exactly what types of tissues the Histotechs gross. Again, I would classify them as level 1 tissues as described earlier in the talk. And they also have some guidelines for each individual tissue. These guidelines are oftentimes posted at the grossing site, which include pictures of what might be seen in a typical tissue of that type, and fill-in-the-blank guidelines for the dictation process itself. I would also highly recommend textbook Surgical Pathology Dissection Illustrated Guide. I have the first edition. The second edition is now available. It talks through the grossing process of each individual tissue that might be seen in the gross room. And finally, there is an online website. Dr. Isaac Dimenstein updates this site periodically that talks about grossing. It has many different articles, even some articles on Histotechs grossing. Talks about derm cases, grossing case studies, and some specific techniques for the gross room itself. And these are some additional references that I used in the preparation of this talk. And again, I'd like to thank you for your attention, and I'd like to thank Sakura once again for allowing me to give this presentation.